Dear colleagues, this is a big pleasure for me to present to you this webinar lecture for kids in Los Angeles for my old friend Sasha Jovanovic. The topic today is early implant placement post-extraction, and this is done together with simultaneous contour augmentation. I want to show to you surgical technique and long-term results. I bring you greetings from my hometown in Switzerland. This is Bern, the capital of Switzerland, and of course you can see that here also the School of Dental Medicine, which is the place where I stay since 1980 when I graduated in dentistry, also many years ago. The School of Dental Medicine, University of Bern, is a center of excellence in the field of implant dentistry, and it all goes back to Professor André Schröder, who started that in the early 1970s. We are active in research, education and patient treatment, and oral surgery has a very close and very synergistic collaboration in all three fields with perio and the pros department. We also work very closely with Professor Belser from Geneva. And you see my own experience as implant surgeon now dates back 32 years, and I continue to treat roughly 150 patients per year. So I'm a very active implant surgeon, and all the cases I'm going to show to you today are my own cases. When we look at the current trends in implant dentistry from a surgical point of view, see we are in routine application. We treat primarily partially edentulous patients with single tooth replacement being number one indication for implant therapy. We do about 70% of all implants as post-extraction implants, and we treat mainly baby boomer patients. The average patient in our department is roughly 60 years of age, also in my age category. Therefore, we have a lot of compromised dentitions and compromised anatomy to deal with. The young patients not very often. So the topic today fits very nicely into this description. Okay, what are the topics we're going to talk? I give you a short introduction, and then we go straight into biologic rationale for early implant placement with simultaneous contour augmentation. Then I'm going to show to you surgical procedures step by step, and then I will present to you long-term results. Okay, implant placement post-extraction, the aesthetic zone, very frequent indication. It's advanced or complex, and the timing is crucial. You see, this is of course well established. Everybody knows that, because when you cannot perform state of the art, you can end up in a really bad disaster. And unfortunately, we see many of these cases these days, these aesthetic failures. When the patients come to us, they normally ask for successful outcomes. They want to have an aesthetic outcome, a functional outcome. For the aesthetics, they would like to have long-term stability, and they want to have a low risk of complications. We call these objectives the primary objectives, because that has the highest priority from our point of view, and we don't want to have problems in this field. But patients, of course, they would like to have the least number of surgical interventions, the least possible pain and morbidity, because they don't like surgeries, they hate pain, they hate morbidity. They want to have short healing periods. And last but not least, they also are aiming at good cost effectiveness, because they pay themselves. Most often in Switzerland, about 90% of the treatments are paid by the patients as a fee for service, and therefore the cost effectiveness is an issue as well. We call these objectives the secondary objectives. That means they are very important. We have done a lot of progress in that field. We have done a lot of fine-tuning of our procedures, but in the hierarchy, these objectives are clearly below the primary objectives. That means when we improve our techniques, we don't want to jeopardize the primary objectives listed above. We have three strategies for our long-term success. You see, we want to stick to evidence-based procedures. because that will help us to achieve these primary objectives. Then, second bullet point, in routine application, we only use biomaterials with a proven record. That means talking about implants, about barrier membranes, about bone grafting procedures. No copycat biomaterials are used in our department. And last point, you see, we have tried to make these treatments more patient-friendly, more attractive. And these fine-tuning efforts in the last 15 years are here to improve these secondary objectives I mentioned before. We know these 4 circles that will influence treatment outcomes. We know that the clinician is most important, therefore this pie is much larger than the 3 other ones. See, the clinician should have skills, should be well educated and should be experienced to tackle these kind of indications. And you see that all the arrows are coming from the pie of the clinician. And when we look at the treatment outcome, the treatment approach, and you see immediate placement is an option, early placement option, or late placement. And the decision what surgical technique you should use clearly dependent on the patient, and this is the patient with all the risk factors. The risk profile, and that includes most often, of course, the local bone and soft tissue anatomy. And that is actually quite an interesting topic. So we have these treatment options well defined. If you want to know more about, let's say, the approach, when to use what, then I would like to refer to the other webinar lecture at Gied Institute, you see, because there we will talking about the tissue biology and treatment options, when to use what. So we gave clear information about immediate implant placement, early placement, but also about late implant placement. Important is to understand today, this is not an either or black and white kind of discussion. We are using all different approaches depending on the clinical situation. And therefore, the situation for the clinician is actually quite attractive. This is all documented in these consensus papers from ITI. These are the proceedings of ITI consensus conferences in 2003, 2008, 2013, published in iChomi. In 2018 will be the next ITI consensus conference, and I'm sure that the topic of post-extraction implant placement will be discussed again, although today we have much more progress than in the beginning. One summarize the tissue alterations, ridge alterations, post-extraction. We learned that timing is most crucial, and ITI already in 2008 clearly indicated that you should stick to the green approach here. You see either immediate or early placement, because then you have an excellent volume of bone, here or here. When you wait longer, then you get a lot of atrophy, and then the exposed implant surface all of a sudden is outside the bone, and that's why it's in red, and that should not be used if it's not mandatory for patient or site-specific reasons. Immediate implant placement, only briefly, you see, has its clear indications, primarily in thick facial walls and thick biotype. That means we know that this is all based on this ITI consensus paper written by Stephen Chen and myself in 2013. And you see here the group of experts that was dealing with that issue. The leader was Dean Morton here from Indianapolis University in the United States. And you see the top expert, of course, is Stephen Chen, which is here. He's from Melbourne University, and he is probably the top expert in that field. See, we came up with these guidelines that we said when you have ideal conditions, intact socket walls, more than 1 millimeter in thickness, thick soft tissue biotype, then immediate implant placement can be done. It should be done flapless, and so on. Now, unfortunately, for central incisors, for canines, a thick facial wall is not very likely, less than 10%. and therefore we recommend to go a little bit less risky. So we recommend an early implant placement with soft tissue healing of 4 to 8 weeks. And the question now is, when is that actually available? You see, inclusion criteria, selection criteria. You see, you go for this approach when you have a thin or a damaged facial bone wall. That would be less than 1 millimeter bone wall thickness. When you have an apical bone wall lesion at the tooth due to endodontic pathology, when you have a crestal bone wall lesion at teeth with a periodontal tissue loss, or you can have a crestal bone wall lesion at teeth with a root fracture. You see, that's very common. You need sufficient bone volume in the apical area because that will allow you to position the implant in the correct 3D position, and in that position you must achieve good primary stability. Big advantage of that approach is that the soft tissue biotype doesn't play a role, and the presence of acute infections doesn't play a role either, because when you pull the tooth, then the cause of infection is gone or eliminated, and then the immune system is going to take care of this infection, and when you put the implant in, the infection is not there anymore. So this is the publication where the biologic rationale and the surgical technique has been described, and it's a paper of methodology together with Stephen Chen, H.P. Weber and Urs Belzer. It was published in 2008. It's a case report, what you see. I'm going to show you a different case now here, and this is a typical case, you see, because the patient has age 73, and she has been referred to the clinic again because I treated her twice, more than 10 years ago, in the left mandible, in the right mandible, very successfully. Both implants are doing great, and now she has a continuous loss of retention of the crown on top of the root number 13, as the canine. And the dentist has decided that the tooth has to be removed. And you cannot see here any visible sign of a facial bone wall, so it must be very thin or not even there. You see a large tooth volume, as often for a canine, and therefore we decided to remove that. Here you see how we proceed. You see the tooth extraction is done without flap elevation, so it's a flapless extraction. We degranulate the area and we use a collagen plug to stabilize the coagulum. You see here that we got a little rupture in the gingiva, that's why I had to apply here a little suture. And then we let the soft tissue heal. And you can see here during the course of healing a little invagination, a little bit soft tissue invagination here, but nicely healed. More keratinized tissue, and this is actually the goal of the soft tissue healing. That's the first point. During that healing, we get also bundle bone resorption. You see, that means the osteoclastic activity will have a boost and then slows down again. And we get a spontaneous soft tissue thickening, and that gives you a thicker flap for surgery. We will come back to that. If there would have been an fistula, fistula is gone, as I mentioned already. The second line here in that slide says that the soft tissue graft with a punch technique is not used in standard cases. I think there's absolutely no need to do that. It only costs money and causes pain to the patient. Doesn't give you any advantage when you do that. It's an overtreatment from my point of view in routine cases. There are, of course, indications when there is a lack of keratinized mucosa. Okay, now I have the big pleasure to present to you for the first time a video clip. This is like a pixel video, an animated video. It was produced by PerioPixel together with our continuing education department, CCDE in Bern, and they paid for that. Also, that's my CE department. It was by oral surgeon Perio, by Professor Sculian. And it's the first time we show it, so I will be very interesting now to see how that shows. I show you a first clip that indicates how the extraction is done. You see, this is our patient, and you see his risk profile. This is the preoperative risk analysis. You see quite some red colors here, 4 times a high-risk situation, but it's a single tooth extraction. This is actually the situation of the original patient. It's a lateral incisor with a root resorption, and you see that the crest width is quite sufficient. And now you see here it's almost like Pixar, huh? Stephen Jobs technology. We mobilize the soft tissues, take a forceps and do a rotational force and get rid of the tooth. And we do a degranulation of the socket to remove any pathology. And then we put a collagen plug, an inexpensive collagen plug in. Collagen, I think, is the technique we are using. Here you see the tooth with an external root resorption, and then we let the soft tissue heal. This is a lateral incisor. I would say normally 4 to 6 weeks is more than enough. We don't have to wait 8 weeks in such a case. Here it shows that in 6 weeks it is done. Now we can show you now with the pixel technology what's going to happen inside the tissue. You see here now that when you look through the tissue that the bone is resorbing and creates this crater-like defect. That's a very typical crater-like defect. And that happens in the mid-facial area, that the facial wall is resorbed. And you see that the defect is primarily filled up with soft tissue. And you see also that the facial soft tissue is coming in, so you get a little bit of flattening. So you get a little bit of an atrophy mid-facially, but there is no reduction in width mesially and distally of that implant site. So that's actually quite interesting. This spontaneous soft tissue thickening has been described in a paper by Vivian Chapuis in Journal of Dental Research. That's the top journal in the whole field of dental medicine in 2015, you see. And it was based on the measurement with cone beams. And we measured the thickness of the soft tissue on top of facial walls and afterwards. And you see here that the soft tissue thickness in thin wall phenotypes where the resorption took place increased from less than 1 millimeter to above 5 millimeter on average. And that shows you that you get in many cases a very nice soft tissue thickening. And you can from a theoretical point of view, look at it like this. You see that the thin wall phenotype resorbs. And then, of course, what happens when the bone resorbs there, that the soft tissue cells from the overlying mucosa have primarily access to that tissue defect. And therefore, you have an ingrowth of soft tissue into that extraction socket in the coronal area, crestal area. And that gives you then this thick mucosal tissue. And now when you use the correct incision technique, you can use it as part of your flap. So in that paper by Vivian Chapuis, you see we said this offers clinical advantages because you get a thicker flap for implant surgery. That flap has a better vascularity and you don't need connective tissue grafting in routine cases. To tell you the truth, you see, in, I don't know, more than 10 years, I have not done a connective tissue graft in our cases, in any of the cases when we did early implant placement, and the treatment outcomes we presented have been considered quite okay. Then 8 weeks, 6 weeks, 8 weeks later, we go into implant surgery, and then one of the discussions we can have is what kind of incision flap design we're going to use. And this is an ongoing debate, in particular with my friend Dennis Tarnow, because Dennis Tarnow, as we all know, is clearly favoring this papilla-sparing incision with a trapezoidal flap design. Now, I always argue with him. You see that in Europe, nobody is doing that. We have been influenced by the Italian perio top surgeons to avoid these vertical incision lines, because we have seen too often then a sort of a scar tissue lines in that area. I came from oral surgery background, and therefore my approach has been often like this. trapezoidal incision, 2 releasing incisions at adjacent teeth, not papilla sparing. This is a typical oral surgery approach. And the third option would be a triangular flap, see, like this. And this triangular flap has been often used by other European colleagues, one of them, for example, Dr. Grunder, and other Italians. We started to use this technique 9 years ago based on a conference where this discussion was really heavily discussed, and I thought it's time to move. When we discussed the various incision designs, you see advantage of papilla sparing incision. It's clear the papillas are not elevated, so you get slightly less bone resorption in the area. You still get some because of the extraction, of course. The disadvantage, you have a small flap, and when you do a contour augmentation and want to build up the facial contour, the flap is too small for a nice adaptation, and that is increasing the risk for scarring. See, there is a debate if this is a scar or not, but I just can say you can see immediately where the incision has been, and this is visible for a long time, and I have seen many of them at conferences in my own patients as well, so it's a fact. Okay, this one, this is the trapezoidal flap design. Advantage, it's a large flap, vascularity is excellent, coverage of contour is no problem. Disadvantage, you have 2 releasing incisions rather close to the tooth we replace, so you can also have there visible scars, and the papillas are elevated. So you get a light resorption of bone due to surgical trauma. That is well documented. The mean bone resorption is about 0.6 millimeter when you use this flap design. The third option is now the triangular flap. This is our favorite. You see here when this is a central incisor here, then we go to the canine. When it's a lateral incisor, we go to the canine or sometimes to the first premolar. That means you try to have the releasing incision outside the aesthetic frame. And in this area here, we often use today a so-called papilla base incision, so we don't mobilize the papilla at all. Okay. How is that incision done? Here you see such a triangular flap, and you see also that we go mid-crestally slightly to the palate. And you see I'm using here a so-called microblade, because the microblade helps me to go nicely into the tissues and try to perform this incision in a slight palatal position. We go back to our pixel video. You see how we start. This is the flattening we have seen here, and you see this soft tissue healing inside the socket. Okay, now you see the incision technique. So we go intrasulcular. This is a 15Z blade. That's also an option. And you see we go slightly palatal mid-crestal, and we go deep into the socket, and we try to, as you can see here, we try to stay to the inner surface of the palatal bone wall, and that maximizes, of course, then that we can get all the soft tissues inside that socket as part of the buccal flap. That gives us a very thick flap. Here you see then papilla base incision and then the releasing incision at the first premolar. Okay, that's a typical triangular flap. And then very careful elevation of the mucoperiosteal flap. So, of course, here in this case it's not bleeding, so we have a much better view. But you see now very nicely, so you go with that instrument deep down at the paddle inner surface, and you grab all the tissue as part of the flap. So you rinse it with water. I hope you appreciate how these computer freaks here, what kind of capabilities they have. This is unbelievable, how they can imitate that. And you see then we are adding here a retraction suture to the soft tissue, and we can keep the flap off with this very nicely. Next step is now how to put an implant in a correct position. This has been described in this paper here, first time in 2004. That's a highly cited paper, more than 300 citations. And we came up there with a concept so-called comfort zone and danger zone. So the implant platform has to be positioned in the comfort zone. And these dimensions are in threefold: mesodistally, coronal-apically, and orofacially. When the implant is inserted, since we have these bundle bone resorbs of the facial wall, then the bone defect on the facial aspect must be a two-wall defect to go ahead with a simultaneous augmentation. Here you see the correct positions. You see the comfort zone is always in green. Most important is this coronal-apical position of the implant shoulder, 3 millimeters here from the mucosal margin. Also, that's an important one. This is 1 to 1.5 millimeter here up distance to the point of emergence. So this is very well established and is nice. What implants do we use? You see in this single tooth replacements, I have a clear preference for bone level implants by Straumann. This is a platform switching type implant with an SLA surface chemically modified. And you see the platform switching gives you here a minimal bone resorption. So the bone can attach to the implant shoulder. You see that here on a radiograph of a 6-year implant, 6 years in place. See, and that is actually a very neat implant for single tooth replacement. It works so well because the two bony structures here are maintained by the adjacent teeth. So in multiple missing tooth situations, I do not use that implant type because there the tissue level implants show better results from my point of view. This has been analyzed very carefully by Vivian Chapuis. I will not go into all these details, but if you want to look it up, this paper is now published on the EPUB and also MedPub electronically. And I show you the next slide, and that actually is the whole thing. This analysis showed, and these are the corresponding numbers. You see here that here you see much more bone loss compared to here. This is the bone level implant, this is the tissue level implant. And you see that here on two typical radiographs that you get a much better maintenance of bone of the facial wall in height when this is a bone level implant. That's an important aspect for the tissue aesthetics, the soft tissue aesthetics. And that's why we are using in these single tooth sites these bone level implants since 10 years now. So here now we have the next video clip. We show you now how the implant bed is prepared. So round burr number 2 prepares into the existing bone apically. Then comes the first spiral drill at 2.2 millimeter with a lot of water cooling, sterile water cooling, chilled. And then we put a depth gauge in to check axes, depth and everything. When we put a 10 millimeter implant in, we prepare at least to 12 millimeters. Then comes the next spiral drill, which is a 2.8 millimeter spiral drill. A depth gauge, again, checks very carefully axis. You see we are perfect in the axis. And then the next drill, this is a small diameter, so 3.5 millimeter bone level implant, the profile drill, and then the implant can be inserted. You see this insertion device has 3 dots. Each dot is a millimeter distance from the implant shoulder. A healing cap is applied so we can extend the implant above the crest. And this now should indicate to you where the implant is positioned. You see we are inside the bone. We are 1 to 1.5 millimeter off the point of emergence. And the two-wall defect morphology will be an easy one to regenerate now. When we summarize this, you see this is a screenshot of this from side view. These are the 1, 2, and 3 millimeter distance. And the CEJ, of course, is not where the mucosal margins are. This is about a half millimeter further apical. You should have the future margin about at 3 millimeters at least. But it's very important when you put implants correctly at this position, you see the implant on the parietal side must be subcrestally. So this must be below the crest. We're going to get a little bit of resorption here as well, but not much. And therefore, you need to have a stable bony situation in this area. And when I give you then here the situation following bone augmentation, we always put a healing cap in. So we actually convert this bone level implant into a tissue level implant, because this is a machined titanium healing cap. And then we perform the bone augmentation to the rim of this healing cap. At the end, the whole soft tissue is sutured over. We have to perform an incision of the periosteum, and this thick tissue flap will be positioned on top, and that gives then an excellent aesthetic outcome. Okay, here you see this bone augmentation procedure. Implant is inserted, 2-wall defect, the healing cap is applied, and now you see that we are using one filler. This is autogenous bone chips, and this is the second filler. This is this low substitution bovine bone graft, DBBM, deproteinized bovine bone mineral. This is BioOS brand name. Why do we use 2 fillers? You see, this is based on preclinical research, intensive preclinical research. Bern probably has the best record in that field, and that is due to Professor Bob Schenk and also Dieter Bossart, because they give us excellent expertise to evaluate these bone fillers in histological studies. And we have learned that autogenous bone chips accelerate, boost immediately new bone formation, whereas DBBM increases the augmentation volume, and it will provide a better volume stability because it has a low substitution rate. Now, these are a lot of claims, you will say, but I will prove that with preclinical data and with clinical data. These are some of the preclinical studies the University of Bern has published. You see, this was the first one I did myself in 1998. That was the eye-opener study. The surgeries were done in 93, 94, and then published in 98. And here we started to understand that there are differences between osteogenic potential and substitution rate. That means some fillers can boost osteoblastic activity, and some fillers do not participate in the bone remodeling. That means they stay there and maintain the volume. And I would like to show you 2 studies that are a typical example for that. You see, these were both done by Simon Jensen. He's a Danish maxillofacial surgeon. He served as ITI scholar in my department, and then maintained an appointment in Bern on a 20-30% basis over many, many years. He was our Mr. Pig surgeon. He did a lot of mini pigs and has published excellent. He's an excellent guy, very smart. And you see here osteogenic potential. That means how much acceleration of bone formation you have, and this is substitution rate. When it's low substitution rate, then you have volume stability. And you can see in the first study, that is from 2006, 2 weeks, 4 weeks, 8 weeks, you see that autogenous bone much faster heals. So you have much more bone formation than all the competitors here. They are lagging behind considerably. When we look at the second study, that goes from 4 weeks to 52 weeks, also a year. And you see exactly the same. In the beginning, autogenous bone is the boost. That is like a hormone. When you look at substitution rate, then a completely different picture. Autogenous bone resorbs. Autogenous bone resorbs. Or here, this is TCP resorbs. This is BCP, TCP content, very much resorbed. The best volume stability you have again for DBBM, that is here and here. It's in the range of 25 to 30%. Here you see a perfect example. This is a 2-week specimen. That's hard to believe. 2 weeks in a mini pig. The defect has been here. Let me show that with some lines here. You see, that was the defect here, here, and here. So 3 walls. So the osteogenic elements, blood vessels, are healing in from the side. And when there is nothing, then you only get that position on the bony walls. When there are bone chips, then you can see that the bone sits, also the osteoblasts are sitting on all these chips immediately and start to form bone. And then you see here this beautiful network. It's like the scaffold, you could say, how these osteoblasts produce osteoid and then woven bone. This is an immature bone. Later on, this will be reinforced with parallel fibered bone, and later on with lamellar bone, and then you get a normal bone structure. Well, this is amazing that at 2 weeks, the whole defect is already healed in these mini pigs. When you go for 8 weeks, then you see the difference between autogenous bone here and DBBM. Huh? You have a high percentage of DBBM visible because this is a DBBM article. You see this is a big piece, a big piece, a big piece. So you have a high percentage, 25%. Autogenous bone, most of the stuff is resorbed. It's about 3 to 4%. So the remodeling takes away the autogenous chips, but not these DBBM particles. Now you might ask, why is autogenous bone so much better in terms of osteogenic potential? And this is something we did not really know for years. Bob Schenk always said, you see that these are non-collagenous proteins that are doing these positive effects. It could also be that the osteocytes play a role. Huh? This is a lot of research going on. It's also clear that the harvesting technique plays a role, because you have to take that autogenous bone either as chips with a scraper or as a block and then crack it down with a bone mill. Important is that we are collecting autogenous chips rather early today during surgery and put them into blood, as you can see here. This is like a blood bath, and then as we could show, and I will show you the papers for that, these bone chips release immediately growth factors into the surrounding blood. Here you see one of these young researchers in our group. You see I have a lot of excellent young researchers, very smart kids. See, they are between 25 and 30 years old, very well educated, very motivated. This is Jordi Caballé Serrano from Barcelona. He's a big Barcelona football fan. And you see here a paper he has written with the group and how to collect that. You can see here how these bone chips have been harvested from pig bone, from the butchery, with the bone scraper. And then with a medium, they collect them and then they do these kind of studies. Today, all the studies we have published are with pig bone. And now we want to repeat those, the most relevant ones, and use autogenous bone chips from human patients, with the blood of these patients. And we will see what these data will give us, but I'm very positive. You can see that the group has published tons of papers, 11 papers in total. And of course, Caballé, so Jordi is very important, and also Rick Myron has been very important, and also Reinhard Gruber. These are the three important cell biologists that have been working in that group and gave us all the expertise. Two most recent ones is when we take this blood, we call the bone conditioned medium. When you take that blood and put it into a dish with DBBM or with membranes, then we could show that both biomaterials absorb immediately this BCM, and then you activate biologically these biomaterials because then when you test them in tissue cultures, then actually they are able to stimulate osteoblasts. And that is actually a very interesting observation. And we're going to have more details to come in the near future. So important is that these autogenous chips are not harvested in the mandible or in the chin or retromolar. You see, we always take these bone chips locally. That means it's the same flap, so it will not cause any additional morbidity. As I said, we take them today very early on and put them into the blood. And the blood there in that blood bath, it stays there for about 20 minutes. We do then all the other steps of surgery, and that is actually quite neat. Here again, our pixel video that shows now how this is done. Also, when the site is open, we collect blood. The implant, as you will see, is not prepared here. And we take that blood and put it in a glass dish. And then we take locally, with flat chisel at the nasal spine, we can take autogenous chips. They are a little bit small here. We could have taken them slightly larger. And these bone chips go into the blood bath. And then we can also take more apically to the implant side. We can also go lateral to the apertura nasalis, you see, and take the bone there. So with a Hufridi bone scraper, and you see these bone chips, they're about 1.5, 2 millimeters in size maximum. They go into this blood, and then they release the growth factors. BMP2, TGF-beta, everything has been documented. We have to release the periosteum when the implant is inserted because we need to release the flap. We often have to open up the marrow cavity lateral to the implant when it's very cortical bone. Of course, inside the bone defect there will be bleeding surface, but here we don't have the blood in this tissue. What we also do after 20 minutes, then we often dilute a little bit with sterile water as a Ringer solution. And then we take this mixture and use it. This is the BCM, the bone condition medium, and we use it then to moisten then the DBBM particles and later on also the membrane. So this is actually quite interesting. The most beautiful aspect is, you see, the bone chips are harvested locally. They are used now to fill up the peri-implant bone defect. So inside the bone, this is all autogenous bone. And then the contour augmentation is done with the DBBM particles, moistened in blood, and you can easily over-contour. That's why it's called contour augmentation. So this is very well documented, as I will show you, used in hundreds of cases over 18 years now. I don't have yet, with the pixel video, the application of the membrane, so that will take another month to do. It's very time consuming. Here you see that we are using collagen-based membranes as a native collagen, a non-cross-linked. It's used in 2 layers again. You see we have one layer here and the other one is here. And then this stabilizes the membrane very nicely. It stabilizes the filler underneath. In such cases, we don't need any fixation pins because the fixation pins I use sometimes when we have very large volumes. We know that East van Urban is using them in the sausage technique, and that's mainly used in the posterior areas. But when you have a case like this with these 2 wall defects, I do not see a need for pins because they have to be removed later on. This membrane selection was done in the middle of 1990s, mainly based on this paper by Hürzeler. We also could document with our own paper by Thomas von Arx, that actually these membranes are very biocompatible. They are not causing any foreign body reaction, and the healing is very nice with these membranes. Last but not least, tension-free primary wound closure. You see, we need to mobilize it with a periodorsal incision. We have seen that. We go for primary wound closure to submerge membrane and augmentation material. And of course, that optimizes the successful regenerative outcome in such a situation. Here, when we summarize in this patient, you see how it was done. Correct positioning, healing cap, then augmentation to the healing cap, then autogenous bone and DBBM, double membrane technique and primary closure. Flap has been mobilized. And here you see that we even tried to do a little bit of coronally advanced flap to minimize the recessions at natural teeth. Patient is 73 years old, you see. The loading protocol, so the healing periods, you could say, is an 8-week healing period in these cases. After 8 weeks, we do then the reopening like a punch. And then in this case, patient went straight into the final restoration. And you see here the lady at the 1-year follow-up, and you see very nice aesthetic outcome. Of course, she's a little bit compromised here, but that's how we started. She's 73. She does not have perfect periodontal conditions, but for that age, I would say it's pretty good. And you see the radiograph shows very nicely healed implant here in the canine area. So when we analyzed this case, patient had a flapless extraction, 2 months of soft tissue healing, then an open flap surgery to perform implant placement, 8 weeks of healing, reopening with a punch. The patient did not have any bone graft harvested at the chin or retromolar, no connective tissue grafting in the palate. She has a low risk of complication as documented by several studies now, and she has excellent long-term chances for good stability on the facial bone. So actually this is a quite decent treatment approach for such a patient. Show you another case, a little bit more demanding because here is nothing left over. Apical lesion here, and we pulled the tooth to get rid of the infection, and 8 weeks of healing. Triangular flap design, you see huge defect here, as a really. This is the W shape, I could say. That's a Grand Canyon type defect. But is it a problem? No, it's not. Because when you look from the occlusal view, when the implant is placed, then you see now we have a nice wall here and we have a nice wall here. It's just a large distance, but nice steps. And of course, I would not put in here just DBBM. That would probably not give the same results. Now you need a very active substance to stimulate autogenous, also these osteoblastic activities, and this is autogenous bone. So we have done here the autogenous bone beautifully, over contouring with DBBM, then membrane in 2 layers, as you see here. We did a little soft tissue punch. You see underneath the previous perforation where the fistula has been at extraction. I just wanted to be on the safe side. This is not done in a routine, but in this case we did it, and then the primary closure. Look here at 8 weeks, punch to reopen, and look where the gummy smile is. She is exposing a lot, so there is no, you cannot take a risk here for a mucosal recession. She would be compromised like hell. You see, this is the provisional. This is the patient at 3 years, 2012. So she was treated in 2009. And you see, excellent, the situation. That's not the best here. This is like an irritation, probably from an ill-fitting crown margin. But what concerned us more, it was this one here. She has a discoloration at this tooth. And we have seen that she starts to resorb that root post-trauma situation. The 3-year radiograph here was excellent. And here now you see the comparison of the radiograph. Also you see here excellent stability. 3 years. Look the bony wall we have. This is all facial bone wall. Was nothing here. At the 5-year follow-up, you see now that she has a new implant in the lateral position. That's here. Well, this is the new implant. And this is the 5-year. This is 5 years. That's an excellent treatment outcome. Look the stability. Look the convexity. She still has some irritation at the natural tooth with the crown. This is not looking good, but here it's much better. That was 2014. If you want to know more about this surgical technique, I can refer you to this CE department. We have there also a video library, not as fancy as that one of Sasha, but we have a certain number available, and I think that is at least an option to consider. Now, what about long-term results? The results are here listed. These are all the publications. We have 2 patient pools that were treated and are now long-term documented. And you see, we started in 2008 with a retrospective analysis, and then here a prospective 1-year data, and then prospective 3-year data, and then here prospective 6-year data in Journal of Dental Research. And that's the paper I want to show you. This is the group of patients, 20 cases consecutively treated, prospectively documented. So far, 0 dropouts, as all patients have been kept under control. And we're going to see these patients again in October this year, 2016. And then we will have 10-year data for this group. Let's see how the patients will look like. And you see we have used in these patients bone level implants, and we did a very thorough analysis. And here you see just one case out of the 20. She has had a lot of probing depth here, and you see huge defect and lots of collapse post-extraction. And you see here the 6-year follow-up. So that is excellent maintenance of the margin. Here we have some resorption at the natural tooth, also recession. And we also have a little step incisally. It's very unusual. Patient is here 48 years of age. So this is quite interesting. When we go for radiograph, then I have to take here the markings off. So you see here excellent stability here, 6 years. And the facial bone wall cone beam, very nice. So this is a very beautiful result at 6 years. Second patient, also one of these 20. She does not care too much about aesthetics, so we could not really remove these amalgam fillings. She still has them. I offered her that we take them off free of charge. She didn't want to have it. That shows you that the priorities in terms of aesthetics are not for all patients the same. The beauty here is that she has a very nice 2-wall defect, very, very deep. This is an excellent, probably V-shape, Swiss Alp Valley, as I mentioned before. And when you look at it, you see here, then you can see that she has excellent 6-year radiographic appearance. You see this is perfectly maintained here and here. Then you see here, what a beautiful facial wall. This is more than 2 millimeters in thickness, more coronally than the implant shoulder, at least 1 millimeter. So this is a perfect result. Was clearly favored by this very favorable bone defect visible here. Here you see all the data we have from that study. This is the modified plaque index, very low, modified sulcus bleeding index, very low. We are not using any bleeding on probing because I do not believe in that around dental implants. Probing depth, very interesting. You see on average more than 4 millimeters. That means on the midfacial, the probing depth is normally 3 millimeters, sometimes even less. But mesially and distally, the probing depths are 6-7 millimeters on a routine. And then keratinized mucosa, more than 4 millimeters. That's for early placement, very typical. And here you see how deep the implant shoulders is located below the margin. It's more than 3 millimeters on average. Of course, in the mesial and distal aspect, they're much deeper than on the facial aspect, and they are the most shallow on the palatal aspect. Here you see now a comparison, 1 year and 6 years, all 20 cases. And of course, you can see immediately that we have different age categories. When we have a young patient, then the result can be absolutely excellent. That is an example of a young patient here. Had very high aesthetic scores. And this is another one here, and so on. And then we have cases where, of course, the neighborhood is a little bit compromised. That's like this one here. We mentioned that before. But the beauty is that none of these patients developed a mucosal recession. We confirmed that with these measurements. We took casts and then measured them optically with this technique. And you see the comparison. This is 1 year, 3 years, and 6 years. So we have very constant conditions here around these implant crowns. Then we did the cone beams at 6 years, and you see that Mrs. M, that is this patient here, is our risk patient because she's the only one that does not show here a radiographic bone. So there is some resorption here. She's our patient at risk, I would say. So 1 out of 20 does not show all the way an intact facial bone wall. When we go into details, then you see here in 70%, also 70% here, we have a perfect facial wall, like this. And then 25%, so bone is like this, a little bit of resorption. And then this is 5%, that is Mrs. M. That's our risk patient. Will be interesting to see how she looks at the 10-year follow-up. The implant is still in place, but I have no clue how the implant is doing right now. I have not seen her for 2 years. When we go for these radiographic values, then you can see very stable situation. And the DIB, that is the distance from the implant shoulder to the first bone implant contact. See, it has been 0 at surgery, and at 6 years it's 0.44. And it's like this because about 3 implants have lost some bone, including Mrs. M, that is this 109. When you go for the thickness of the facial bone wall at 2, 4, and 6 millimeters from the implant shoulder, you see here 1.745, 1.96, 1.93. And you see, of course, small values, the minimum values, that's Mrs. M, 0.2, 0.14. Also, that's minimal. Final question. What is in that bone wall? You see, because when we see radiographically bone, then it doesn't mean that it is bone. It could be something else. And of course, we cannot take biopsies on a routine in our patients from a ethical point of view. But we have a study published now, 2014, that gave us a chance in 10 patients to take human biopsies. And it was published again by Dr. Simon Jensen here in Journal of Perio. And I show you just a typical example. This is a patient we did in 2004, implant placement with a typical contour augmentation. Also, as we have done it, as we have seen it, and then she was restored in private office. 2008, she comes back, had a root fracture at the central incisor, and gets a new implant there, you see. And I took the chance to go here with the incision over the exposed implant that was placed before and took a biopsy here. And this is not a biopsy. So you can see beautifully, this is an artifact rupture, but the rest is fully intact. Here you see now, this is bios, and this is bone. And you see here these cement lines, and you see blood vessels. So this is nicely vascularized bone structure. And you can see that the DBBM particles are not resorbed at all. So they maintain the volume. So obviously the osteoclasts, being part of that bone remodeling, cannot resorb the DBBM. That's an interesting phenomenon. Nobody knows exactly why, but I'm sure we're going to figure that out once. And when you analyze this, you can see that, that the percentage of DBBM particles, which is the blue bars, varies between here 18% and here 42%. And you see that the standard the mean value is 32%, and you see here standard deviation 9.6. So that's actually nicely confirming all our animal data we have had before, because there it was between 25, 30, 34%, depending which surgery we have analyzed. So the conclusion, this paper is the first human biopsy to confirm the low substitution rate of DBBM for contour augmentation. Okay, with that we come to our conclusions. We are almost through. I wanted to show you. Early implant placement with soft tissue healing. This is this type 2 placement. Is most often used by our group in these cases where we have a thin wall or a damaged wall. It's combined with rather short healing periods post-implant placement. So 6 to 8 weeks of healing is sufficient in daily practice. Contour augmentation is routinely performed with GBR, and we go for primary wound closure to protect these biomaterials. That means we don't use immediate restorations in aesthetic signal tooth sites for early placement. Okay. Now, contour augmentation. This technique is well documented for post-extraction implant placement, has a low risk of aesthetic complications as shown by several studies. The utilization of autogenous bone grafts offers a faster healing and shorter healing periods, whereas the DBBM particles, they offer better augmentation volume and long-term stability. The long-term stability of contour augmentation is documented with cone beam studies. Soon we're going to have a 10-year study available. So when we look again into this immediate placement, early placement, or late implant placement, all of them can be used. You see the different percentages, 5 to 20%, less than 2%, more than 80%. It depends where you put the implant in. When it's a central incisor site, then it's probably only 5–7% of the cases where you can do immediate implant placement, from my point of view. When it is in the first premolar site, then it's much higher. But from a percentage point of view, the early implant placement is clearly most often used. And it's probably a very good treatment protocol for younger colleagues when they get into that field, because it has a low risk of complications. And with this technique, you can easily build up your competence level, and you can increase your experience very nicely. Okay, I mentioned already that at University of Bern, that's also, of course, not as active as SCID Institute, but we are running 3 different master courses, very, very popular from all over the place in Europe. So this is a nice addition to what we have here in Los Angeles. And since we are having the same protocols, similar philosophies for so many years, Sasha and myself, this is great to see that these offerings are available on different continents. With that, I would like to thank you very much for your kind attention. You see, it has been a pleasure to lecture here in a webinar style, and I hope to do that again once in the near future.
For more education programs, visit the Guide Institute at www.guidedental.com.